condition, so esophagus, stomach, small bowel. And there's our objectives, everything we're gonna talk about today, so there's quite a bit involved with most of them. A lot of them have similar treatments, but we'll get into the details here. It's important to look at the anatomy first. We're gonna start at the esophagus and work our way down. So it's got two mucosal layers. The more distal in the esophagus, you'll have smooth muscle, which is typically where we find most of our issues with a lot of these conditions. So, you know, it's important to think about that when we're trying to diagnose what's going on. So most fertility issues are going to be affecting smooth muscle. And then, you know, it's important to just understand how long the esophagus is and where we run into problems. And then where those junctions are. And then we talk about on there like where we have our portal hypertension and varices, so they kind of wrap around on there. So that can be something that we see as well in the esophagus, or if it's not in it, but it surrounds it. That's something we can also see, which we're not covering today. We'll talk about that in liver pathology, which is the next lecture. But starting off, so we have Zenker's diverticulum. So this is basically just a pouch, and it's the most common diverticulum we see, and it's typically located just above the cricopharyngeus muscle, and so you get this outpouching in there. And then typically patients complain of dysphagia, they might have halitosis, some sort of throat discomfort. You might feel a palpable mass on exam. And then they sometimes complain of like a lot of regurgitated food. And then sometimes you can have like an aspiration pneumonia from it as well. So how do we diagnose this? As you can see on the image there, we use a barium study. So they swallow some contrast, and then we run the imaging. We typically don't want to do most of the other conditions we're going to talk about. We typically want to do like an EGD or a scope so we can actually visualize what we're looking at. This one we don't, just because you run a risk of perforation or perforating the pouch. So we typically stick with the barium study. And there's our cricopharyngeus muscle, so it's just above that is where we typically find these. And the treatment is surgical. So it's a cricopharyngeal myotomy. Depending on the size of it, it'll just depend on whether we have to use like a linear stapler versus just removing it. But what we have to consider here is we have a nerve that runs through there, the recurrent laryngeal nerve. So that's always something we have to take into consideration when we're working on these patients. And we don't damage that nerve. It's typically an easy procedure. It's got a great prognosis, very few complications. But it is the most common diverticulum we see. And then GERD. Anybody had GERD in here? It's not fun. Yeah. I've never had GERD, but I've had heartburn a couple times. It's, not pleasant. Patients, it is a very common thing you're going to see in the outpatient clinic. We see it in the ER all the time. And sometimes it can be associated with hiatal hernias, which we'll talk about next. But we have two different syndromes with this. We have esophageal and extraesophageal. So esophageal's the more common one, and that's typically you have your heartburn, dysphagia, chest pain. They may complain like regurgitation symptoms. Sometimes they feel like something's refluxing into their esophagus. What should concern you guys is if they have extraesophageal symptoms. They have a cough, hoarseness. They might complain of less specific features of it. Sometimes people will complain of weight loss with it. That should concern you guys. Any progressive dysphagia, GI bleeding. And then we're going to talk about what we do for these folks. So typically the diagnosis, we don't need to do any special testing for this. We treat them symptomatically as long as they don't have any of those concerning symptoms like we saw in the last slide, like any weight loss or progressive dysphagia, bleeding, vomiting. We typically treat them with a trial of either some sort of antacid type medication or anti-reflux meds. Typically, sometimes we start with an H2 blocker or a PPI. PPIs usually work a little better, but sometimes we can start with our least invasive. So sometimes we like to use, have you guys heard of famotidine or Pepcid? That's a very common one we use. And then another great over-the-counter like PPI is Prilosec is commonly used, and then we move up to like pantoprazole or Protonix, which is a little bit more expensive, but all of them you can purchase them over the counter. We typically give them a trial of like an 8-week trial on this. And then if there's no symptomatic response, we'll usually give them 8 weeks more, and then we just give it to them twice a day for the medication, so one in the morning, one in the evening. The important thing to consider is if this fails, then we need to refer them for more testing. The gold standard is the pH testing. So it's your ambulatory pH monitoring is typically what we do for them. Now, if we're concerned, like if there's a Barrett's esophagus, or depending on the length of their symptoms, sometimes we'll refer them to GI for an EGD so they can get scoped and they can confirm on there whether it's Barrett's esophagus or there's any other signs of malignancy that might be concerning that we need to check for. All right, so like I said, we give them a trial of acid suppression therapy, lifestyle modifications. PPIs are the strongest medications, but we can also give an H2 blocker initially as well. If we suspect any like peptic ulcer disease, we'll talk about later, we usually start with a PPI because they're a little bit stronger and work better. And then if they have the persistent symptoms, that's when we, on the PPI therapy, that's when we look at doing the further workup. And there are surgical management. The most common procedure we do is laparoscopic Nissen butt application. So very common procedure. That's for those who fail outpatient therapy, or if they have those extraesophageal symptoms, we want to give them, we want to refer them to surgery. And as you see on the pictures, they just kind of wrap it around, and it helps reinforce that gastroesophageal junction. And then swallowed foreign bodies. This is always a fun one. So kids, they like to swallow everything, coins, whatever they can get their hands on. So what concerns us are typically if they have any, if they swallowed anything sharp. You may see this also like in somebody who's an alcoholic or pica as well. That's something you'll see like a guy brought his 3-year-old girl and was like, she's been eating dirt, and I was like, well, yeah, she's a kid. I mean, kids eat dirt, and he's like, no, she's like eating dirt, like eating lots of dirt every day. And I was like, oh, that's kind of weird. I shouldn't have had pica. She had a like pretty significant anemia, but it was just funny. And then, so what we have to worry about with these patients, so most things just pass through the body without any concern. If it makes it, past the esophagus, they usually, most things pass on their own. If it's metallic, that's great because we can get imaging, like an X-ray, and we can just kind of monitor its progress through the GI tract. So typically we'll get an X-ray if it's in, if it's past the esophagus and it's not a sharp object, then we typically just have them follow up with their PCM in like, 72 hours, or they can return to the ER and they get another X-ray just to make sure whatever they had passed. Sometimes you can, monitor stool. You can tell them to do that as well and see if they can visualize it, and they don't have to come back. But what we worry about is if they're able to, if they're still tolerating secretion. So if they're not able to swallow saliva, that's more of a concern that there's a total obstruction. And that's when we have to do a little bit further workup on them, or possibly consult for endoscopy so we can remove it. But the initial diagnostic test is obviously just plain films wherever we suspect it is. The nice, typically kids, the most common swallow, so you can get one plain film usually covers most, from the neck usually down the pelvis, and depending on how old they are. Usually it's younger kids that are eating things. And then we also have to worry about, sometimes they can aspirate it as well. Like I had a 14-year-old come in, he just had upper respiratory infection, got a chest x-ray on him, and there's a nail in his lung, and I was like, what the heck? I was like, that's weird. I didn't mention anything about the nail in his lung, so went and talked to him and showed him the x-ray, and the guy was like, or the kid was like, oh yeah, I was hanging a picture like last year, and I was nailing it on the wall, and I lost a nail. I guess I inhaled it, and it actually ended up being really bad for him. So since it had been over, it wasn't simple. Since it had been over a year, the only treatment, like when I talked to the pulmonologist and the cardiothoracic surgeon, and they were like, he'll actually need a lobectomy. That had to remove his lobe. Yeah, it was kind of sad, but he did fine. But things to consider when they swallow them, like we have where the physical narrowing is. So like you have your, most proximal is your cricopharyngeus muscle, which we just talked about, like where you get your Zenker's diverticulum. And then just distally at the aortic arch and then the lower esophageal sphincter are the narrowing points where you may have objects that get lodged in the esophagus. And that's when typically they'll complain of those more concerning symptoms like the dysphagia, drooling, but they should otherwise be hemodynamically stable. So if they're stable, then just, plain films, and then possibly consult if it's still in the esophagus for a scope and see if they can remove it, if it's already passed and it's not one of those concerning sharp objects. And we'll talk about other issues too, like button batteries are always the worst. But, so obviously airway is our first priority. As long as the airway is intact, we can look at going through our, further treatments or diagnostic studies like the x-rays. Like I said, if it's like blunt, short, narrow, depending on the size, how sharp it is. People swallow toothpicks a lot as well, so those are typical things you'll see. A lot of like fish bones, they'll eat those and they'll kind of get, lodged in the esophagus. But usually once it makes it in, through the esophagus, they usually pass on it naturally. But things to be concerned about are, like I was talking about, those little disc batteries, or we call them button batteries. So those can actually cause a liquefaction necrosis. So your digestive enzymes will break those down, and those can then cause a liquefaction necrosis, and it can be a very big problem. So you can get like esophageal perforations, or it can also happen in the GI tract as well, further down in the GI tract. Other issues we see commonly in kids are like those swallowed magnets. So when they swallow multiple magnets, then you run the risk of them, magnetizing somewhere in the GI tract, and it can cause a big issue. So those are other concerning things we see oftentimes. And then let's talk about some perforations. So esophageal perforations is typically caused by us, so some sort of scope. So it should concern you if you see a patient, they come in and they just had a scope, so it's important with your history. And then obviously it's influenced by where the perforation was, and it's actually got a pretty high morbidity and mortality for this if it's not caught in the first 24 hours. So, the patient doesn't present pretty soon afterwards. It's got a pretty significant morbidity associated with it. But like I said, the most common cause is us doing it to the patient. It's usually in the cervical esophagus and the cricopharyngeal area. And if it's, minor and it's in the first 24 hours, a lot of times, sometimes you can manage them with just antibiotics alone, but the issue is infection. So this can then kind of seep down in the thoracic cavity, and typically it's on the left side, and that causes a really bad sepsis. So it is something we always need to consider. We also have Boerhaave syndrome, which is a spontaneous perforation. This is usually associated with like heavy eating and drinking. And like I said, it most commonly occurs on the left side, just from usually the violent retching and vomiting. They typically have, will complain of pain, and they'll usually have a lot more symptoms. If it's in the thoracic cavity, they're going to be sick. They're going to be tachycardic, tachypneic, dyspneic, might have some hypotension. It can cause a pneumothorax. It can cause, an empyema as well. So once you get that, you can also get this from trauma too, which is like 10% of the cases can be from penetrating trauma. And this is when you see, have you guys heard of your crunch up mon, which is basically the air that's leaked in there. And you hear this crunching sound when you're listening to their heart. And then what do we do for this? So we typically start with our plain films. It's the easiest and the quickest to get. So typically we start with a chest x-ray. Sometimes, we may involve the neck as well, depending on where they're complaining of the pain, but usually chest x-ray to start with. And then if we're suspecting this, we need to get an esophagram, which is like our barium swallow. We like to use water-soluble contrast on this just because if we suspect that we have a perforation, we don't want to put contrast in there because it can be irritating and worsen the condition. So we typically start with the water-soluble contrast, and then we'll use a CT scan as well, typically in these patients. If they have like a pleural effusion on there, we may have to do a thoracentesis just to draw the fluid off and get a measurement on it. Sometimes these perforations are hard to diagnose. So a lot of it is based on like your history and the symptoms they have. in your physical exam, so sometimes we do have to put a needle in and draw off some fluid and run it for sampling, so they'll typically have an elevated amylase level. Their serum amylase might be high as well. So it's something you gotta consider in your initial workup, because a lot of times we don't get an amylase on everybody, so you know, you have to have a high suspicion, or at least a little bit. What's up?
We also have blood in it?
It may or may not have blood in it. Typically, they don't have any blood. But yeah, this one is broad spectrum antibiotics. Immediately, you need to have, you know, wide coverage on that. But most commonly, it's like staph, strep, pseudomonas. So you're covering, you know, for your gram positives and your anaerobes. And then typically we like to operate before 24 hours, or else they have a very high mortality rate. Like it says on there, it drops to 50%. If there's any delay in this. And that's why like the last one we talked about, like if they had any sort of instrumentation, that's why we counsel, you know, they counsel them pretty heavily, like any issues in the next 24 hours, you need to go to the ER immediately, because that can be very concerning. And then, you know, because people don't like to make mistakes, then you usually sit there arguing with the gastroenterologist, and they tell you they didn't do it, we're like, well, it looks like something happened to them. You wanna come down and take a look at this guy, or gal? All right. So patient with a history of alcoholism, vomiting bright red blood, presents with ED with chest pain, fever, nausea. Which of the following findings suggest he has a rupture of the esophagus? Yeah, the subcutaneous emphysema. So we talked about the Quentran-Mon, but you can also have air kind of leak anywhere along the esophagus if it's not in the chest. So you may have subcutaneous emphysema, like when you're palpating the neck. So it's a classic finding for this. And then there are other esophageal injuries, like the Mallory-Weiss tear can sometimes be confusing with like Boerhaave, but typically Mallory-Weiss has like your upper GI bleeding, so you'll have usually vomiting that turns, you know, that started non-bloody and then progressed to bloody. These ones actually heal pretty well on their own, like 90% of the cases heal on their own. So we usually don't do any intervention as long as they're stable, which is, you know, what I would recommend, how you guys are looking at, obviously your patient, especially your, like, when you're looking at a test question, you need to start with, are they stable or unstable? And then you need to evaluate from there, because resuscitating them is usually the first priority. But these are usually just expectant management. We typically don't have to do anything for these patients other than monitor them until it improves and the bleeding stops. All right, what else can happen in the esophagus? So, you know, people like to swallow or drink things. If any of you, like I know some of you were medics in here before, I'm sure you've had like somebody somehow always drinks JP8 or fuel for some reason. Don't know how that happens, but it does. Somebody filled a coffee pot with it once at our aid station, oddly enough. We didn't drink it, but I mean, usually when it has a pretty strong fuel smell, usually you should be smart enough not to take a drink out of that. But you have your different types of corrosive agents. So you have your acids and alkalines. Alkalines are the most common, and they're the worst. So the alkaline agents lead to a liquefactive necrosis, and they can cause perforation. So that's what concerns us the most. Typically, like bleach is a very common one, or any of the other cleaning agents are typically more alkaline, and they cause the most damage. Acids usually transit through the esophagus quickly enough where it doesn't cause any like coagulation necrosis or anything. So they're usually not as bad. And then they'll obviously have usually some sort of complaint like dysphagia, drooling. They might have chest pain, abdominal pain. If there's a perforation, then you're going to see those really sick patients that have fever, tachycardic. They'll, you know, present with those shock type symptoms. And then if it's perforated, you will have some subcutaneous emphysema. We typically start with like, you know, chest X-ray on these patients. We resuscitate them. And what we don't want to do is try to use anything to like counteract that agent that they swallowed. So we're typically not neutralizing it. We don't want to make them vomit, because we do that in a lot of patients. We give them some sort of emetic agent, depending on what they've swallowed or what type of ingestion it is, but not in these ones for these corrosive agents. Like we don't want to use any NG tubes. We typically consult GI so that they can take a look at the esophagus and evaluate how bad the corrosive agent is or what sort of damage it has caused. But what you commonly see after this is strictures in these patients, which can be very concerning. So that's why we follow them up typically every 4 weeks, doing a barium study. Sometimes they won't know that they had, they won't come in and present with this. So sometimes you'll first, you might see them months or a year later with a stricture, and they have some sort of foreign body sensation stuck in their throat, which is a, common presentation as well. But, this typically, this is not good. Like, the outcomes on these are not great. So it's usually like a multidisciplinary team when we take care of these folks, just because we're going to need GI to do the scope. We'll usually have to contact poison control as well, and they'll help kind of guide us on what the agent they swallowed was, because sometimes it'll be some random strange cleaning agent you've never heard of. You don't know if it's alkaline or acidic, so if you call them, it's nice because they can pull it up real quick, tell you everything you should do for the patient, and like 95% of the time you call poison control, they're like, oh yeah, there's symptomatic management, observation. But if you're unsure of the agent or what it is or what it does, then just give them a call. All right, let's talk about some cancer. So, esophageal cancer, it's less, not as common in the United States, but it is still something that we may see typically in like 50 to 70-year-olds, more common in Asia, Africa, Iran. Adenocarcinoma makes up the majority of these patients. And then you have your squamous cell, which is typically associated with alcohol and smoking. But adenocarcinoma is more associated with like Barrett's esophagus, which is why a lot of times we'll refer them to get EGD so they can biopsy that tissue and they can take a look and evaluate. Unfortunately, there's not a great cure for this. So most of these patients, we can't do much for. Like I said, it's 15% cure rate in the US. So a lot of times, it's, they'll go to like hospice or something like that, or we'll put them on some kind of care plan. Unfortunately, yeah, these patients don't do very well. And that's because it's mostly asymptomatic, so they don't present until it's an advanced stage of the disease, but dysphagia is the most common symptom that they have. They'll complain of solids first, followed by liquids. They might have some weight loss. If it's metastasized, you might get the bony pain in there. If it's invasion of the recurrent laryngeal nerve, like the hoarseness. Sometimes we'll have respiratory symptoms or fistula. We have, a bunch of different imaging studies we can do. So, obviously we want to refer them for an endoscopy. You may get a barium swallow as well, depending on if you're managing inpatient or outpatient. And they can do a bronch if they're worried about it, if they're worried about any tracheobronchial tree involvement. And then most of them do get some sort of CT scans. You can get a PET scan as well if you're worried about metastases. And then the most sensitive test for determining the penetration of the tumor is going to be your ultrasound test, your endoscopic ultrasound. And you can also do finding biopsies from those or aspiration. You can check lymph nodes. And then a bone scan if you're worried about metastases as well. But the most accurate for the tumor staging is going to be your endoscopic ultrasound. So treatment's based on the stage of the cancer. So if it's something that we think we can resect, we will. A lot of times, the tumor will be too large, so we'll have to give some neoadjuvant chemo first until we can shrink the tumor to a size that's resectable. And then, there are other procedures like an esophagectomy. I've never seen that done. That doesn't sound great to me. But obviously removing the esophagus and then moving like your stomach or colon replaces it. So it's a pretty significant large procedure, which is why it has a high mortality associated with it. And then, like I said, the advanced disease, you'll have like your palliative care or hospice care. So we don't really do a lot for them at that point. We just try to help them with their like activities of daily living, and they can still swallow and eat. But any way you treat this, you still have like a 25% survival rate. So it's no bueno. All right, let's talk about the stomach and the small bowel. So I'm not going to bore you guys to death on the anatomy, but it is important to remember like where the jejunum starts and it begins to ligament and trites. And it just helps us identify whether it's stomach, whether it's like duodenum, small bowel, and so we kind of run through small intestine on where we think that injury is, or the most common, physiology we're going to see with it. So we'll start with hiatal hernia. So this is actually pretty common, so 10% of the population. They're usually pretty benign. Most of them are classified as a type 1, which is like your sliding hiatal hernia. So it kind of slides up into the esophagus, and they'll, they may be asymptomatic. They may just complain of reflux symptoms. What concerns us is if it's like a type 2 to 4, which is less common. This is when you have your risk of like incarceration and strangulation, like I talked about. So all hernias, we have our risk of incarceration, which means we can't reduce it. So it's stuck in whatever place that is. And then strangulation is when you have some sort of bowel contents get in there and the blood supply gets cut off to them. And then it leads to necrosis. So that's what strangulation is. It's always important to remember the difference between those. So like I said, many patients are asymptomatic. If they have symptoms, typically your heartburn, regurgitation type symptoms. And since type 1 is the most common, that's usually what you'll hear. Which is why we like to, when I was talking about the GERDs, a lot of times they start with just GERD symptoms. We treat them just like everybody else, usually like the 8-week therapy. We'll up it to twice a day for another 8 weeks. If they're still symptomatic, then we move into the further pH testing of their treatments, but this is when an EGD can be helpful, so they can evaluate the gastroesophageal junction. A barium contrast study works well too. And then sometimes we can just get plain films, just looking for any air in the mediastinum or air fluid level mediastinum. So what do we do for it? So it's a laparoscopic Nissen and fundoplication, just like we do for the GERD as well, that isn't amenable to oral therapy. There is a new procedure, it's kind of cool. So basically they just put a ring around to help reinforce the gastroesophageal junction. And so, it's less invasive, and it does the same thing as if we do the Nissen fundoplication, so it just reinforces that junction with magnets. So, it's kind of a cool procedure, and it does have similar improvement rates as the Nissen fundoplication. So that's another option we can do nowadays too. Bariatric surgery. So I don't know if I'm biased because I only see problems in the, I only see the people who have issues in the ER, but we see a lot of bariatric surgery complications after it, I feel like. So obviously obesity is a problem, especially in the United States right now, so that's anything with a BMI over 30. I'm not sure, so this was typically the most effective, or the only effective intervention for morbid obesity, and maybe when we're talking about morbid, which is like over 40, I think over 35 or 40 BMI. But now that we have Ozempic and everything, I would hope that this is probably, I would hope that Ozempic is fixing that a little bit, so we're not having to do as many of these procedures. But we used to use a lap band, which you'll still see patients with that, and they just have a high rate of complications, and we don't like to do it anymore. So now, we have a couple different procedures we do, but here are some of the guidelines that we'll talk about the procedures. But BMI typically greater than 40. If it's over 35 with comorbidities, then we may consider them for bariatric surgery as well. There is talks of, or there's newer evidence, I've seen patients who are very, I think they were just overweight and they already got a bariatric surgery. So there are some places that have loosened the guidelines a little bit for these surgeries, which is just like what you see with Ozempic, right? You see sort of diabetes, and now you see just about everybody. I know pretty young, healthy people that are on Ozempic. I think they're just trying to look better. So we have to always think about that, other options as well. But so this obviously expanded its indication just like Ozempic did when it started there. So insurance pays for it, and that's the whole, the ultimate decider in the end is whether the patient's going to pay for it or insurance. And once insurance starts paying for it for these other indications, then you'll see it a lot more frequently. But this started, they started to do it in adolescents even as well, which is interesting. I haven't seen an adolescent get it, but that's definitely a consideration out there. So we typically were doing the Roux-en-Y was the most common one we used. And then now we're doing the laparoscopic sleeve gastrectomy. So the Roux-en-Y, I mean, it had a great improvement, but it also had significant complications with that. So typically in the first 30 days after this procedure, you'll have the dehydration and some sort of electrolyte abnormality. And then what we worry about, especially in the ER, is like an anastomotic leak. And the issue with these is it requires like multiple barium swallows and a CT scan, so it's just a long protocol, which is why we don't like it in the ER. That's just because we have to sit there for like 4 hours usually waiting, and it's just different time studies checking for an anastomotic leak. But now that we have the sleeve gastrectomy, it's improved those complications, so we don't have as many with it. It's a shorter learning curve, and basically, as you can see on the picture, we're basically removing most of their stomach and just creating a small sleeve there, so that they, basically their body tells them they can't eat anymore, and so it curbs their appetite. But it is very effective. Peptic ulcer disease. So this is pretty common. It's becoming less common because we treat H. pylori a lot more now. But it used to be very common before H. pylori treatment. We still see it, 10% of the patients. Usually it's from H. pylori and NSAIDs are the most common we see. Sometimes you'll have that hypersecretory state, which we'll talk about, Zollinger-Ellison syndrome in the next few slides coming up. But what's important is determining where it is, so whether it's duodenal ulcer versus a gastric ulcer. Sometimes you can tell by symptoms. I mean, I think that's a little hard. You have to have a really good historian. The patient has to be a great historian to tell you. So it's a little bit more difficult, but most commonly they're duodenal ulcers. And they usually, it's usually a few hours after meals, temporarily with food, can awaken the patient at night. With the gastric ulcer, it's typically aggravated by the meal, but they're a lot less common than duodenal ulcers. And like your average patient is usually like, 40-year-old, your typical patient that's going to have duodenal ulcers. So for the gastric ulcers, endoscopy is it's the best method we have for diagnosing these, and it also provides us an opportunity for biopsies as well and testing for H. pylori. If we suspect, the difference is the gastric ulcers have a lot higher rate of malignancy. So for those, they'll get multiple biopsies, just evaluating the ulcers, since it has a high malignancy rate. So they'll typically have to go in there like 6 times and do different biopsies. They'll have to get the edges, just like you do on the skin as well. If we have, if you've ever heard of the Mohs procedure, you guys taking Derm yet? That's right. Well, you'll learn about it coming up and how we have to. Basically, we like to limit the amount of tissue we take, so we take it in very thin, one layer at a time, and then we put it under microscopes and look at this. That's why it requires multiple procedures. But yeah, unfortunately, lab tests don't help us much with these. Neither do CT scans as well. CT scans are like 30% sensitivity on this, so those don't help us either. Sometimes, some variant studies can if it pools in the ulcer, but that's very rare. And then we'll talk about Zollinger-Ellison syndrome in a moment, but if that's suspected, then you want to get that fasting serum gastrin level. And then, so Zollinger-Ellison syndrome, this is that hypersecretory state that we were talking about. And it can be associated with, severe peptic ulcer disease. This can be like your GERD patient that fails therapy. And really, it's usually from a tumor near the pancreas, and it just produces that hypersecretory state or increased gastrin, and then they'll get multiple ulcers. So this is one that we consider if we've treated that patient, or if they've already gotten a biopsy of it and they're still having, refractory ulcers or they're recurrent ulcers, then that's when you need to think about Zollinger-Ellison syndrome and draw these additional labs that we have on here, which we'll get into here. So here's, the first one is the elevated fasting serum gastrin level. And then we kind of have our algorithm there. You guys don't need to get too in the weeds on the algorithm. Just remember, like, your fasting serum gastrin level is important. And then if that's abnormal, then you need to get like a secretin provocative test. Or if it's borderline, you may have to go down that route. but this typically they'll require a lot higher doses of PPI, so we usually start with like usually, depending on which one it is, like 20 milligrams twice a day, and then sometimes we'll up it to 40 twice a day. So usually patients that require a lot more therapy, and that's when you should start thinking, okay, they're taking, the typical treatment isn't helping them, so we need to increase those doses. And think about these other syndromes that we have here. And the treatment is surgical resection. So H. pylori, we have good therapy. That's the amoxicillin, clarithromycin, and a PPI typically for a few weeks. And this is how we're avoiding, like why peptic ulcer is, a little bit less common. I mean, we still see it frequently, but not as common as we used to. And then we usually do like a test of cure for these patients as well, which is your urea breath testing. Most of these are managed medically, so they will, if we think it's like in the stomach, then a lot of times we will get that EGD, they'll do the biopsies and testing. If it's bleeding, they may get like an angiography or embolization. So here are duodenal ulcers. These are the most common. This is typically your younger patient. Like I said, it's kind of declining right now, but we still see in the military we prescribe NSAIDs for everything, so we give Motrin to everybody. So it is something we need to consider, and it's a great question, great history question asking your patients whether they took any NSAIDs. And a lot of times they'll tell you they're not taking medications because it's not something prescribed; it's over the counter. So it's always important to ask them about what sort of NSAIDs they're taking, and obviously. COX-2 inhibitors have less risk, but we still aren't commonly giving them as first-line agents, and COX-2s aren't over-the-counter medicines either. So that's why a lot of times you'll still see patients taking a lot of that Motrin or naproxen over-the-counter. And the complications from these are, depending on whether it goes, which wall it goes through, you're going to have, we got some pictures here, on whether it perforates versus hemorrhage. And typically duodenal ulcers aren't associated with cancer, which is why we don't need to do as many of the biopsies for them. But they'll have that burning, dull, gnawing epigastric pain. Typically it's relieved with a meal later in the day. And we will, sometimes we're on EGD, we may just treat them symptomatically if they're not having any sort of like hematemesis. And then we can certainly do like a gastric analysis and the fasting serum gastrin if they're recurrent or they've had more than one ulcer. And then here's a great representation of it. Depending on whether it's in the outer wall or where it's located, on whether it bleeds versus whether it perforates and just causes air. So if you guys remember that X-ray with the air under the diaphragms, like they'll have that pneumoperitoneum, and that's usually a perforation versus if it goes through, depending on which wall it goes through, it might just bleed and they'll have hematemesis. So what do we do for these patients? What's important, obviously resuscitate them. So sometimes they can have pretty significant hematemesis or upper GI bleeding. So we have to resuscitate them first. So obviously, if depending on how significant bleeding is, we'll typically start with crystalloids. If there's significant bleeding, then we move to blood products. But the most important treatment for them to start with is your PPI. So a lot of times we'll use H2 blockers if it's like mild, but not for ulcers. That's just for GERD. So we typically don't use those because they're not as effective. Like pantoprazole, it's also called Protonix. That's probably, I think that's the only one we have that's IV is why we use it the most for these patients. So obviously resuscitate them first. Are they stable, unstable? Do we need to get blood on board? And then, once we have them stable, we'll usually refer them to an EGD, and they can do cautery, they can do clips, they can do sclerosing agents to help with that bleeding. But first we have to stabilize them, and then if all of that fails, we then move to like interventional radiology if your facility has it. And then when do we do surgery on these patients? This is what's important is, let's say you have a patient, they had a bleeding ulcer, they got cauterization through the EGD cauterization, and then they become like hypotensive, tachycardic, they require multiple units over 3 of PRBCs. that's a patient we're gonna have to take to surgery for this, just because they're unstable. So it's important to differentiate in your history and during your treatment, the route they're going. So if we can improve them with, a couple of units of PRBCs, that's great, but a lot of times they'll have pretty significant hypovolemia or hemorrhagic shock. And so a lot of times we will have to take them to surgery. And then here are some of the different procedures that we can use for this. So we can do just ligation of the bleeding vessel, they can do an antrectomy, and then sometimes you can, if it's in the duodenum, a lot of times you can just use pyloroplasty, which is basically just putting a patch on it, like an omental patch, and just kind of patching it up. So that's typically for the duodenum. If they're, if it's gastric, then typically require more invasive procedure. And then, yeah, you can do reconstruction and resection. Those are pretty significant procedures, and those are for patients who aren't amenable to any of the other, like the omental patch. So it just depends, every patient is different, so it depends on your patient presentation and what we're treating them for, and what sort of surgery they're going to get for these. And then obviously, any sort of surgery is going to have complications, but especially when we're involved in the GI tract anyway. Just to get a lot of bacteria that live there. So an antrectomy definitely has lots of complications with it, but leakage for the duodenal stump is probably one of the most significant that we have to be concerned for. So they'll typically open them up and do the operation, washout and drainage. If there's any delayed gastric emptying, we typically manage that conservatively, and we just monitor them until they improve. For like truncal vagotomies, is typically a similar presentation. They'll have like that delayed gastric emptying, dumping syndrome, which we'll talk about here in a little bit. And then depending on how much of the stomach you remove, they're obviously not going to be able to tolerate large meals. And then you also have to think about other conditions that can cause like gastric atony. They may be on prolonged NG suctioning, and you may have to give them TPN feedings as well until everything heals. So these are all considerations like we talked about how we're going to give them, how we're going to give them feedings so that they're not malnourished. So like if it's longer, like we said, typically like over 6 to 8 weeks, they'll get a J tube in there, and they'll get their feedings through their J tube. And then dumping syndrome is very common after these procedures. You're going to see it in most patients. It typically improves. They're going to have varying symptoms, but usually they're like cardiovascular or GI. So they'll get like, they'll come in and complain like, hey, whenever I eat, I get palpitations, I start sweating, flushing, I get nausea and some cramping. The important thing to consider is like, we don't do a lot for these other than diet therapy. So we just counsel them, you eat like your low carb diet, high in fat and proteins, and it works in almost all the cases. But this can last for a few months after surgery, which is why patients, present and are very concerned about it. But our management is typically just dietary change or therapy with these patients. All right, I'll give you guys a second to read this one. So, a good way to look at these questions, is this patient stable or unstable? Unstable, right? Why? Yeah, so, yep, tachycardic, tachypnic, febrile. Blood pressure is a little soft, technically not, hypotension yet, but it's getting there. So it's important this is an easy question, so this is, perforated ulcer. But when you're reading a lot of these questions, when you're looking at, when we give you different options, like what sort of therapy do they require, you need to start with, are they stable or unstable? So if they're unstable, then we have to resuscitate them before we do anything. So it's important to keep that in mind when you guys are reading these questions, okay? All right, let's take a 10-minute break, and then we'll talk about some gastric cancer, stomach cancer, More common in like Japan and China. Typically males greater than females, and usually in like 7th decade of life. This is like your elderly patient, and we've seen like a strong association with like H. pylori, which is why it's probably less common in the United States, because we do a decent job at treating that. But it does have a strong association with it, and typically it just causes like some sort of chronic inflammation, which can then lead to cancer. For these ones, the best way to diagnose it is with an upper GI endoscopy, and they have to get a biopsy with it. Our upper GI series aren't as great. We may get a CT scan just for staging, but it's not going to be something we typically use to diagnosis. However, I have seen this in the ER, and we've caught what we think is a malignancy on CT scan and had to refer them, unfortunately. It may be something that's noted on CT scan and they may need a referral for, but all of them need a upper GI endoscopy with a biopsy, so an EGD. And then we do our, tumor node, metastasis staging. You guys remember all those? No? All right. Well, we're not going to get too into details on that, but that's typically how we stage a lot of the cancers. So tumor node, metastasis, and we just want to basically isolate where the tumor is, has it spread to any lymph nodes, and has it metastasized. So if it's isolated, we usually just do like endoscopic mucosal resection. If it's transmural, then we'll have to do like a gastric resection. We'll have to evaluate the lymph nodes for just to check this, if it spread to lymph nodes, and then we have to worry about metastases. But the only cure for this is going to be resection. Now let's talk about the little babies. You guys remember this one, the little olive-shaped mass, projectile, non-bilious emesis? Yeah, typically, it says, 4 to 6 weeks of life, typically 3 to 6 after birth. They usually present with that, non-bilious emesis. Projectile vomiting is what the parents complain of. It's difficult because parents, especially what I've noticed is if it's their first kid, they bring them in for everything. So you'll see a lot of, what they say is projectile vomiting, and you'll have to evaluate these patients quite frequently. But what you need to consider is they probably haven't been getting adequate feedings for quite a while, probably since birth. So they will tend to present with like a metabolic alkalosis. You'll need to do aggressive rehydration on them. So it's important that we resuscitate them first, and then you may have that palpable, olive-shaped mass in the epigastrium. And the best way to diagnose is ultrasound, which is great because it's, no radiation exposure. It's quick, it's easy, it's cheap. That's the best test we can do for this one. And then it's a laparoscopic pyloromyotomy for these patients. So they typically tolerate it well, very few complications. But it is something we need to consider when we see that patient that has that non-bilious projectile vomiting and they're in the right age group. And then small bowel obstruction, I know we talked about this a little bit here on our previous lectures, but obviously we said the most common cause from an adhesion. You can also see it with a hernia as well and some tumors. They may have a volvulus, intussusception, or ileus, which we'll talk about those in a moment. But this one is like they're usually going to complain of like pretty significant pain. They'll have distension, and they'll be usually PO intolerant, so they'll have nausea, vomiting. This is one where you can see those air fluid levels like on the plain film there. And if it's, what we have to decide is whether it's, pain from a mechanical obstruction versus an ileus. So the ileus typically has like diffuse pain. It's usually milder, and this is where the history is important. Have they had some sort of recent surgical procedure? Have they been under anesthesia? Have they started new medications? So that can kind of help differentiate a little bit when you're trying to evaluate what the difference is. Like I said, it's important to ask them about their past surgical history. So if they had any belly surgeries, which I ask every belly pain patient, hey, have you had any surgeries in the belly before? The reason I say belly is they don't know what happened means half the time. So I try to keep it simple for them. But this one, we don't actually do a lot of this other than NG tube and resuscitate them. So first we need to evaluate stable, unstable, and then we need to start our resuscitation based on that. So typically they'll get fluids. We'll place an NG tube in them, and then we usually just do serial exams. We visit them in the hospital until this improves. And then that's when we're doing our resuscitation fluids, followed by our maintenance fluids and just serial evaluations. They can have significant electrolyte abnormalities, which, like I said, all of our abdominal pain patients, we usually get that CBC, CMP, lipase, UA on these patients, but most of them resolve spontaneously, which is the good part. They don't require any surgery or anything like that. And then, so yeah, obviously some sort of abdominal surgery, so we'll have the adhesions. And then you can also have some like peritonitis if those adhesive bands like kinked in the stomach can cause like a volvulus or any of those other complications you can see with this. So that may be a little bit more concerning, but you'll see the air fluid levels like in that x-ray there. And then we need to make sure that we resuscitate them. And then incarcerated hernia, we can see a small bowel obstruction with that. And like I said, that's where it's a non-reducible hernia. And then what we have to worry about is whether it's, strangulated or not. So that's going to be, and you guys will actually see this in clinic, and you'll have to, hopefully you get a good class or some great training on actually checking for hernia in your hernia exam. But these are important, and sometimes they require quite a bit of pressure to put that hernia back in, but it is something you guys, if you find a hernia on exam, you need to try to reduce it in your clinic when you're evaluating them to determine whether it's incarcerated. And if it's strangulated, they'll typically have those sepsis type symptoms, so like fever, tachycardia, the mental status may change. But these ones are typically going to need surgery. If it's just routine, you're able to reduce it. That's usually like an outpatient surgery. If it's not reducible, then it's typically something that needs to be operated on immediately. So we'll usually, refer them to surgery immediately, or they'll get surgery right then. And then if it's strangulated, that's an emergency. So they'll get surgery ASAP. And then there's our volvulus. So that's usually like a closed loop obstruction. It has a high risk of strangulation, infarction, perforation. As you can see in the bottom right image there, that's that like bird beak deformity that you guys have probably heard in the past. They may see other things, but they'll typically present with, the same as just a normal small bowel obstruction, but usually they'll have a lot more significant tenderness and distension on exam. And the most common one we see is like a sigmoid volvulus. You can get abdominal radiographs. CT is typically better to evaluate this, which most of the patients are going to be getting a CT scan. If it's questionable, sometimes you may have to do like a barium enema, so you may have to do that, like rectal contrast. And like I told you guys, don't volunteer to do that. Yes. So yeah, they'll typically have some sort of systemic toxicity. They might have, rectal bleeding, but usually they have a fever. They're a lot more sick than your typical small bowel obstruction patient. And like we said, depending on where it's located, they will undergo immediate operation. If they're stable, we might do the barium enema first, just that if the diagnosis is inconclusive on the CT, they may do the barium enema to find where that lead point is or where the obstruction is. And then intussusception. So this is the telescoping of the bowel. This one would be very tricky, especially, you'll see it obviously in adults if they've had some sort of surgery before, but it's most commonly in younger age. So they're typically like babies or in infants, usually like up to 2 years old. And this will be one that presents with, they may have the Crohn's jelly stool, they may have the sausage-like mass. It sounds great on a test. It's not typically what they present with, but it's colicky. That's the issue. So when you have that telescoping of the bowel, it spontaneously resolves. So a lot of times the parents will complain, they'll cry for 15 to 30 minutes. They'll bring their legs up. They'll be very uncomfortable and they'll be perfect after it. So that's something that should help kind of guide you, especially if they're complaining of these symptoms. And when you evaluate the baby, they look great. So it's something you always have to kind of keep in your mind on the differential. And this one, the best way to diagnose it is with an ultrasound, so you can see that target sign like we have on there, which is telescoping of the bowel. And then the treatment is barium enema, so it's usually pretty minimally invasive to treat this and improve the symptoms, but it is always something to have on your differential, especially when you're treating kids. All right. Ultrasound. Barium minima is the treatment. I mean, it can be diagnostic as well, but typically we start with an ultrasound and then they'll get a barium minima right after that. All right, which of the following common causes of small bowel obstruction is most likely to occur in adults? Yeah, adhesions. I feel like we'd like to beat that dead horse for the adhesions and small bowel obstructions. All right, and so less common, but you can have like an internal hernia, which usually from some sort of adhesion causes strangulation of the bowel. But unfortunately, it's not something that we can, see on exam. A lot of times it'll be associated with trauma, and this is somebody that usually has to get an X-lap and opened up in order for us to cure this. But it is something to consider if you have that, if they have some sort of, like the right presentation, like a trauma patient or an MDC, you need to think about this. And we'll get a lot more in depth in block 3 when we talk about trauma and seatbelt signs, all that fun stuff that can help guide you on your exam. But it is always something to consider in the right patient population. And then we have our gallstone ileus. This is rare. I've never seen it yet, but we always talk about it. And this is really, you have a gallstone that basically it basically perforates the wall of the gallbladder and then into somewhere in the intestines. And this can be the cause of a small bowel obstruction. And then, they have that classic abdominal radiograph findings of regular triad. So you may see some air in the gallbladder, and they should have a bowel obstruction, and then you'll see a gallstone on the X-ray typically. That's your Rigler's triad. It's rare, so probably not going to see it, but it is an interesting triad to think about. Most of them are diagnosed with CT scans, so like I said, we typically don't get plain films on the belly, and then they'll typically have to do an enteral lithotomy to remove it. And then Meckel's, we kind of talked about those. This is the rule of twos, 2-year-olds, twice as many males to females, 2% of the population, and then 2 types of tissue, 2 feet from the ileocecal valve. This is typically going to present with lower GI bleeding, so you'll get some sort of hematochezia, and typically the parents will complain about it. They'll usually bring you bloody diapers, or they'll take really nasty pictures that you don't want to look at. But it does help you kind of identify what the condition is. The symptoms are similar to appendicitis, and if we find it, we remove the Meckel's diverticulum, and we also remove the appendix as well prophylactically when we diagnose these patients. And then we always have to consider Crohn's disease as well when we're looking at small bowel obstructions, especially if you have that patient that hasn't had surgeries for adhesions. We need to start thinking about other conditions. They'll typically complain of some sort of GI discomfort, typically months to years when they're undiagnosed. Like I just diagnosed like a 21-year-old in the ER a couple months back with this. He was having like significant diarrhea for months, just like non-specific abdominal pain. He didn't find it funny when after the history, I was like, man, that sounds pretty shitty. He did not laugh or change his face. I was like, okay, well, that was the wrong patient to say that to. I thought it was funny, but apparently it wasn't. So this is when, when they do the scope on them, you'll typically see the cobblestone, skip lesions, it'll be transmural. And we typically treat this with those 5-ASA drugs, steroids. If we're worried about infection, we'll get antibiotics as well. And then they can do palliative therapy. We usually start with palliative therapy, and then if that fails, we'll look at surgical intervention. Unfortunately, they're pretty significant surgeries, so there are a lot of complications, which is why we try to manage them medically first before we do any sort of procedures on them. But we do a small bowel strictureplasty for it. They're going to have usually lifelong complications afterwards, so they'll still be usually beyond the 5-ASA meds and steroids for life, but it is, an unfortunate condition, and you guys will see this. And then small bowel cancer. This is rare, so typically when we have some sort of tumor in the small bowel, it's usually benign, so like 2/3 are benign. Like it says, or 1/3 are benign, 2/3 malignant, sorry, I'm mix it up, but most commonly adenocarcinoma, you may see some endocrine tumors. These are a lot less common than all the other ones. The other cancers you may see, so we don't treat it very often. And one of the issues is they're asymptomatic most of the time, especially when they're benign, with the benign ones, so maybe something incidentally you notice. Like I said, when you're doing like a CT scan or something, they say, hey, there's concern for some sort of bowel tumor, and then we'll have to work them up further to determine whether it's malignant versus benign. And then if they have that carcinoid tumor, they may have other symptoms that are more like sympathetic related, like hot flashes, bronchospasms, arrhythmia. So you always have to consider that if they're having additional symptoms with it that we typically wouldn't associate with, some sort of bowel cancer. But it's always good to keep it on your differential. And then this pill thing has been on here since like I went through IPAP. I've never seen it. I don't think they do it, but it sounds really cool. I would think nowadays maybe they have something better, but we don't have it, especially in military treatment facilities. But I mean, I think it's a great idea. You got a little camera, you swallow the pill, and it goes through the bowel. You can evaluate it, but typically they'll have to get some sort of scope or CT versus MRI versus barium studies. We can use nuclear medicine scans for these as well. But it's not something you guys are going to see very often. All right, so you got a 35-year-old, acute bowel obstruction, has a history of abdominal surgery, so it's always important in the history. And I'm not going to insult your guys' intelligence. Hopefully you remember the most common cause of small bowel obstruction there. All right, and then a Bezoar. So this is usually a foreign material, causes small bowel obstruction in the GI tract. Typically, like some sort of vegetable fiber. I know like broccoli is one that is implicated, a lot of times. This is basically just some sort of like fibrous material gets lodged in the bowel and it can cause an obstruction. Typically, like this is something to consider in those diabetic patients that have gastroparesis. Or if they've had some sort of abdominal surgery, it's something to consider as well. But the initial plain film is helpful in this one, and it can typically, depending on the location, they can fix it with just endoscopy. So you can get a scope down there and kind of remove it. All right, I know it was a lot to cover. What questions you guys have? Nothing? Gotta have something. Oh, last, this one? This one's adhesion, adhesive interintestinal bands. Yep. And that's why it's important to pay attention. Like, typically we don't tell you the surgical history in a lot of the questions, so like that's something to think about when you read that, like, oh, why did they give me the surgical history? So some of those things can help, guide you when you're reading some of these questions. And especially in real life, obviously, like I said, all abdominal pain patients want to know if they had any sort of surgery before when they're coming in with belly pain. All right, what else y'all got? Nothing? Well, that's all I got for you.